Great. Well, thank you, everybody, for participating in this. It's great to meet you all virtually. I am going to share a little bit about the history of iTriage, how we think about the world from a consumer focus, and where we're headed, and some of the experience that we've had and lessons learned, because I'm sure a lot of you are thinking about how do we position our technology and companies in the future to be more consumer focused and meeting people where they would like to be in the future. So our company was really founded after spending years working in the emergency department, experiencing some of the problems that people face every day. In fact, in the emergency department, about 140 million times a year in the U.S. alone. And Wayne and I, after Wayne Garrett's another ER doc, after about 50,000 patients over 20 years, started to see a lot of patterns in the kind of patient or in the kind of problems that patients and consumers experience when entering the healthcare system for an acute problem or an acute exacerbation of a chronic problem, or sometimes chronic or very minor problems as well. How did they think about their issues before they arrived? What was their experience like in the emergency department? What were the issues related to their follow-up and understanding of their condition? And what we saw was lots of area for innovation and for entrepreneurial initiatives. Our approach was really to think about the patient from a different perspective. We thought that if there was an initiative that really bet on human nature, so an individual's interest in understanding the condition and treatment and potential complications and issues, that they would be motivated to do so because, obviously they're the one with the condition. But there were so many places to look, and a lot of the information on the web just, wasn't very effective. And all of our training was really focused on a paternalistic way of delivering care. And so our thought and our thesis in the beginning was, let's give the information we have, both in medical content, how that medical content is related and how it impacts decisions on access to care, and let's try to put that into a framework that people can use. Now, as you can see, we had very humble beginnings. There's a lot better technology products now to design products for mobile, but in 2008, there wasn't a lot out there. So we ended up tracing phones and building screens and starting out from scratch with a model that we called the symptom to provider pathway, which allowed people to enter at any point that they needed, from what could be causing my problem to where should I go, to am I covered, and eventually what will it cost me. We also started the company at kind of a bad time in the stock market, but the caveat there is that when people are losing money in the public markets, they are more inclined to look at private investments. So we had a couple things going for us from our experience, but we certainly were building what we saw as a very new product that relied on completely new content, and we were trying to build it at a very difficult time in our economic history. The one thing going for us was a bet on mobile. And so when the App Store came out in the summer of 2008, we thought this was potentially the best way to distribute software that we had ever seen. Wireless connectivity that downloads software right into your phone. You had never been able to do that before with smartphones. It was all an enterprise decision from the carrier or smartphone company on what kind of basic modules they wanted to offer. So this was really a free-for-all. And we thought if we could build great content and functionality and get the three Ps, payers, providers, and patients, to all start using the system to communicate and connect, that we would have a chance. And fortunately, we bet on a technology that now we have seen grow at blistering rates. faster than really any other kind of technology we've seen in the last couple decades. At the same time, I think we're seeing a trend in consumerism where some of the last bastions of non-transparent markets are being opened up by consumer demand, by economic realities and necessities, like the Accountable Care legislation, the impact or percentage of costs that we spend currently in healthcare, and a growing demand for consumer experience. And I think that's coming from new generations and percolating up to really every age category within our population. People want to know information before they seek care. They want access to online appointments. They are very likely to act when they use a mobile device to get information. So you might say, looking retrospectively, as we say in medicine, the retrospectoscope, why is this disruptive? This seems simple. Take symptom checkers, connect them to some decision support and provider directories. There wasn't anything like that when we started, and I think we'll see more evolving. But I think, going back to the history of medicine, we really did not involve the patient enough in the process of everything from diagnostics to follow-up care. Again, it was a very paternalistic model. And I think what we're seeing is if you empower people with information that's simple to access and easy to use, it has a chance of impacting behavior, and we have some really great statistics on this from millions of uses of our product, and those will lead to better outcomes. People don't need to seek really expensive care to be treated for common, simple problems. And so if you segment all the different problems people have and how you can use information to help them self-navigate, there's a lot of potential waste in the system that can be removed. In fact, if you look at some of the studies, like this was something done by AARP that showed that more activated or empowered patients had better outcomes, less medical errors, better confidence in the system, and that all matters in a retail environment where hospitals and doctors will be competing more and more so for patients. And so, our belief is that patient engagement will improve healthcare outcomes. Is this completely out of left field? Is this a completely new concept? Well, obviously not. When I traveled around the world in the early 90s, I called one of these people to book me tickets, and by the time I got to some countries, the airlines didn't exist anymore, and my tickets were not valid. Now everyone does everything by mobile phone or by web for travel booking for the most part. Same thing with many other industries like the financial industry, et cetera. So we thought if we could create a nice, simple user interface that allowed people to jump into the different workflows that they needed to solve, that we could help facilitate the same transition from a paternalistic to really a self-directed type of environment. That has led to a lot of clients around the country. So we work with providers all around the country. As this graphic depicts, about 20% of the acute hospital market is now participating in our platform and saying, we want to provide more information about our facility so that the patients in our area, when they're looking for care, can connect to the right doctor in our network. This really follows population for the most part. We have had now over 11 million downloads. The slide is a month or so old. And I'm sorry, there's a issue here with PCs versus Macs on the PowerPoint, so you may see a few typos. Over 80 million uses of our product a year by people trying to navigate information, connect to doctors, find the right facilities or doctors, and book appointments, or take action. This has generated billions of page views that are all organized in problem-solving pathways, which gives us a lot of intelligence on how people think about, react to, and pursue care for either exacerbations of their chronic disease, which we generally track based on the conditions they save into their own profile, or how they approach acute care. Our vital signs, though, are the reviews that we get from people using our product, and we've had now nearly 100,000 reviews with a 4.5-star rating that we've been able to retain with that scale of use. So I imagine lots of you are either interested in connecting some of your data or your insurance network or your provider organization with a product like iTriage that has the right kind of methodology, the right kind of workflows, and the right scale of users so that you can actually impact either the medical spend or the patient volume or the coordination of care that you're interested in delivering to the marketplace. And so, there's a couple lessons that we've learned that I thought I would share as well. I think some of you have probably seen this graph before, thinking about moving from fee-for-service to a value model and starting to take risk on a per-provider level, either within a health system or a medical group, et cetera. This revenue transition period is going to be a lot harder than we anticipate. I anticipate there will be many hospitals that will either need to be bailed out or will need to be very, very rapidly moving and adopting of value-based models of reimbursement once this transition occurs. That is all predicated on this transition moving, as quickly as I think some people have modeled. So does our system of giving people information, placing a bet on human nature that they will use information to make appropriate level decisions once their medical spend percentages go up, which I think we're seeing about 40% of the medical dollar now is spent by consumers. Will a system like that have an impact? Well, what we're seeing is that for providers participating in our network, so if you're a hospital system in a city in the United States and you want people around you to find your doctors, your ER, your urgent cares, your outpatient facilities, you can add information to our product for an annual fee to make that easier for patients to find that information right within the workflow of their looking for care. In addition, we can connect to your HIT system and allow you to show appointment availability, ER wait times, and also notify the ER or urgent care that you're on your way. Those increase engagement enormously within certain market service areas. And so what we're seeing is that information alone will steer people 19 times more frequently than if you're just a basic listing in our application, and we try to have every facility and doctor that we can find and verify in our system. So adding information increases some steerage. Adding information plus functionality is the holy grail and drives a lot more engagement with your facility. Now what we're seeing is that patients make better decisions also for acute care when they see an urgent care as an option for the condition they're worried about. In fact, we have a 40% lower ER selection rate for lower acuity problems that we list in urgent care as being appropriate. So if you bring that to scale within a population, it's quite significant savings when you look at an average ER cost of $2,500 versus $150 or $250 for an urgent care based on the severity. People are also searching symptoms, reviewing conditions, learning more about medications. So, increasing their overall health literacy. When we work with health centers, we drive new patients, 35% new patients. Within a short period of time, we generate real volume that's meaningful, and generally more commercially insured patients than a typical walk-in ER patient. That results then in repeat visits as well to the facility. So, this information and this connectivity is really important to consumers. As we're advancing our roadmap, there are many different things we will be building as additional functionality within the platform as well. And we try also, and I think it's a really good lesson, we try to do this within the consumer digital group at Aetna, and it's a heavy lift, and we've done this within our company for the last 5 years, is instead of studying and planning and doing waterfall-based technology development, we are very iterative and very agile and have multiple releases every year. In fact, we test our products on our patients instead of studying first and then releasing something that may no longer be relevant.